On behalf of the Hypertension Education Editors, we are excited to have you join us for this webinar presented in collaboration with the AHA Council on Hypertension SCILL Committee as part of the Hypertension Education Series, aka Hype Ed Series. This series focuses on the presentation of hypertension position papers. Today, we will hear about hypertension in patients treated with in-center maintenance hemodialysis. We would like to thank Trudy Meyer, Managing Editor of the Journal Hypertension, for organizing and publicizing this event, and also Angela Bynum of the AHA for critical input and additional publicity through the Council on Hypertension SCILL Committee. We hope this educational collaborative will continue. Dr. Bean Dhaun of the University of Edinburgh and I, Stephen Crowley from Duke, will moderate this session, which will be constituted by a 25-minute position paper presentation and a 20-minute patient case presentation, followed by 15 minutes of question and answer. So please place questions into the Q&A window as we go along. I can't promise we will get to all of your questions, but we will try. I will now mention our panelists, but to leave time for the program, these introductions will not at all do them justice. For this session, we are fortunate enough to have two distinguished speakers presenting the manuscript and an associated patient case. In fact, two patient cases. Dr. Nisha Bansal, first author on the manuscript, is the Arthur Stack Family Endowed Professor in the Division of Nephrology at the University of Washington and the chair of the AHA Scientific Committee for the Kidney and Cardiovascular Disease Council. She will discuss the highlights of the position paper. Then her colleague, Dr. Jordy Cohen, Associate Professor of Medicine and Epidemiology in the Renal Electrolyte and Hypertension Division at the University of Pennsylvania, and Chair of the AHA's Hypertension Science Committee, will provide two case presentations for discussion as time permits. To provide additional context during the Q&A, we have two more distinguished panelist discussions on the line. Dr. Wanpen Vongpatanasin is Professor of Medicine and the Director of the AHA Comprehensive Hypertension Center at UT Southwestern Medical Center. And Dr. Janice Lee is Professor of Medicine, Chief Medical Director of Dialysis, and Director of the Nephrology Division at Emory University. We would very much like to thank our speakers and panelists for their time and participation today. Now I will hand the electronic podium over to Dr. Bansal for the presentation. Thank you.
Thank you, Dr. Crowley, for that really kind introduction and for the opportunity to speak today. So I have the pleasure of kicking us off. So I'm going to go ahead and share my slides. Okay. All right. So today we're going to talk about the scientific statement that was published in the Hypertension Journal, entitled Hypertension in Patients Treated with In-Center Hemodialysis, Current Evidence and Future Opportunities. And I just wanted to call out the scientific statement that I mentioned that is published in Hypertension and to acknowledge the many co-authors that contributed to this work. So a brief outline of what we're going to cover in the next 20 minutes. We'll briefly discuss the epidemiology of hypertension in patients treated with hemodialysis, discuss the pathophysiology, the definitions of hypertension, how to measure blood pressure, and finally how to treat blood pressure. So in patients treated with hemodialysis, hypertension is nearly universal. We know that greater than 500,000 patients in the United States are treated with hemodialysis. And if you look at this patient population, they're extremely high risk. They have a 10-fold higher risk of death compared with age-matched controls. And in fact, the leading cause of death by far is cardiovascular complications, with contributing to 50% of the mortality rate in patients on dialysis. And hypertension is seen in greater than 80%, as many of 90% of patients who are treated with dialysis. So it's a huge problem. And hypertension is one of the strongest and importantly modifiable risk factors for cardiovascular disease and death, which is why we pay so much attention to blood pressure in this population. And it's important to note that patients who have kidney failure and treated with dialysis, the pathophysiology of hypertension differs from that of patients that do not have kidney failure. So in patients who have kidney failure, we certainly see a higher proportion of what I would consider traditional risk factors for hypertension: older age, sedentary lifestyles, and other traditional risk factors. But really, what we really focus on in the management of these patients is these kidney-specific risk factors that likely contribute to hypertension. And these include volume overload, arterial stiffness, activation of hormonal pathways, including the RAS system, the sympathetic nervous system, endothelial dysfunction, and even some of the medications we use in treating this population. And I just wanted to take a moment to highlight a few of these kidney-specific mechanisms that we see in this population. We certainly can't cover all of them in the interest of time. One thing that we're going to discuss a lot today, including in our patient cases, is the role of volume status. And we know that volume overload is a critical component of contributing to hypertension in this population. And so in patients who have kidney failure, we see activation of the renal sympathetic nervous system, the RAS system, which leads to alterations in sodium and water handling in the kidney, leading to decreased urine sodium excretion, which causes intravascular blood volume expansion, and then eventually hypertension. Additionally, arterial stiffness and endothelial dysfunctions are predominant mechanisms that contribute to hypertension in this population. There are various mechanisms that upstream that lead to endothelial dysfunction and arterial stiffness, and include inflammation, the role of uremic toxins that build up in the setting of kidney failure, and metabolic and hormonal disturbances. And the end organ damage that happens in response to these altered pathways includes arterial plaque composition, in which we've seen that there's some differences in how these plaques form and the compositions of these plaques in the arteries. So for example, we see that there's a higher lipid core with lower fibrous volume, more cholesterol crystals, and a higher calcium composition. There's also a difference in the distribution of these plaques and calcification in these arteries compared with those without kidney disease. So in patients who have kidney disease, and in particularly those with kidney failure, we see a high proportion of intimal calcification, certainly, and you can see here in this drawing that you can see this intimal plaque here, which also contributes to high blood pressure. But then we also see that in patients who have kidney failure, they also have a lot of calcification in the medial aspect of the artery. And so this leads to this stiffness and, again, high blood pressure. And so knowing all of these mechanisms, we see that there, as I mentioned, there's a very high prevalence of hypertension in this population. So it's important to think about, well, what is hypertension? How do we define it then in patients who have kidney failure? And so, this is actually a tough question. You would think this is pretty straightforward, but in fact, we have limited data on how best to define hypertension in patients who are treated with dialysis. And this is a summary of major guideline societies, including the JNC8, the American Heart Association, the American College of Cardiology, Hypertension in Canada, as well as the Kidney Disease Guideline Committee, KDIGO, who've all published guidelines related to blood pressure management in this population. However, their guidelines have really focused on non-dialysis chronic kidney disease patients. And so there's less that we know and less consensus or agreement in terms of what are the definitions of hypertension in patients treated with dialysis. I think some older guideline recommendations, but the ones that I think are probably best accepted right now are those from KDOQI, which is also a kidney guideline group, and who suggested that pre-dialysis blood pressure greater than 140/90 or post-dialysis blood pressure of greater than 130/80 would meet criteria for hypertension in dialysis patients. And what we've learned is that the setting and timing of blood pressures in relationship to dialysis actually matter. So patients who are treated with dialysis have blood pressures prior to the start of their dialysis treatment, after the completion of their treatment, and then in between these treatments. And in fact, we've seen that there's differential associations between the timing of these blood pressure measurements and clinical outcomes. And so these are data from an observational cohort of over 300 patients who are treated with dialysis. in which we looked at the association of pre-dialysis blood pressure and risk of death. And so here is a spline, and here on the y-axis you have the hazard ratio for death. Along the x-axis you have the level of systolic blood pressure, and this is again pre-dialysis systolic blood pressure. You can see this very strong U-shaped association between where both high and low blood pressure are associated with higher risk of death. And the nadir of this U is around 140 to 160. In these same patients, we looked at blood pressure that was measured on a non-dialysis day. And in contrast to this U shape that we observed previously, we see now this very straight, linear, and direct association between a higher level of systolic blood pressure measured on a non-dialysis day and risk of death. And so why is there a discordance? There's we don't know all the answers to this. Some hypotheses include that there's poor quality of blood pressure measurements during dialysis. There could be confounding from comorbid conditions that cause lower blood pressure that manifest at the time of dialysis, and that intradialytic blood pressure and volume changes during dialysis are contributing to these differences. And so because of these different associations that we see, there's been some questions of, well, how best should we measure this blood pressure on a non-dialysis day? And so, the two probably most commonly used approaches could be, one is to look at 44-hour ambulatory blood pressure monitoring. And I would say this is really gold standard. And so for this, you place the blood pressure monitor on the patient at the completion of dialysis, and they wear it for the interim 44 hours until their next dialysis session, approximately 2 days later. And so, the power of this is that it accounts for physiologic changes, during the entire intradialytic period. And as you can imagine, that's a very hemodynamically and physiologically dynamic period as a patient, finishes dialysis and nears the need for their subsequent treatment. And 44-hour ambulatory blood pressure monitoring has been shown to be a superior predictor of mortality compared with pre-dialysis blood pressure. One caveat is that it does require more effort from the patients and could be burdensome and may not be available in all places for our patients. Another alternative to measure intradialytic blood pressure could include home blood pressure monitoring. And studies have shown that there is a strong correlation of interim home blood pressures with 44 ambulatory blood pressure monitoring. The recommendation would be to measure home blood pressures on a non-dialysis day. The frequency or the number of home blood pressure measurements are not clear or known. We do have some trial evidence. This is the DRIP trial, which was led by Rajiv Agrawal, which showed that home blood pressure actually correlated closely with changes in volume status compared with pre or post dialysis blood pressures. So that's very reassuring. And we have observational data that has demonstrated associations with cardiovascular events and death, but certainly to move home blood pressure forward in this population, clinical trials are needed. Another important aspect of measuring and treating blood pressure in patients treated with hemodialysis is obtaining standardized measurements of blood pressure. This is really critical to acquisition of accurate and actionable blood pressures. However, there's some challenges with this in patients treated with hemodialysis. There may be limited time to take standardized blood pressures at the dialysis units. The dialysis units are very busy places where they're getting patients on and off the machines and under a very tight schedule. There might be some physiologic differences, including vascular access, as well as arterial stiffness, as well as peripheral arterial disease that can actually affect the measurement of blood pressure. So all considerations when thinking about the blood pressures that you're obtaining in this patients. Just to put a plug out there, I think there is a real urgent need to validate automated blood pressure devices in this population. To date, none have been specifically validated for this population. And the question commonly comes up, well, what about cuffless blood pressure measurements? Note about these devices, they use pulse transit time, pulse arrival time, tonometry, and pulse wave analysis to estimate blood pressure, so it's not a direct measure of blood pressure. It assumes a certain vascular characteristics of the patients when they're obtaining these estimates. And again, I think we have some ways to go in terms of validating cuffless blood pressure measurements in all populations, but specifically in dialysis patients as well. And so once we've measured blood pressure, how do we figure out which targets we should be going for? And so I think this remains an area of future research. We do not have widely accepted blood pressure targets in hemodialysis patients, but I do think that there's been some good progress in this space. I'd like to recognize the blood pressure and dialysis trial, or the BID trial, that was published in 2018, in which they randomized 126 hemodialysis patients to 2 pre-dialysis systolic blood pressure targets. One was less than 140 versus less than 155. And this was a feasibility trial. And so so they weren't looking for efficacy, but really to see if it was feasible for patients to achieve these treatment targets. And in fact, they did show separation between the 2 groups. And importantly, they did find a possible safety signal with higher vascular access thromboses with the lower treatment target. So these data have to be confirmed with future trials, but again, a step in the right direction to think about blood pressure targets in this population. So I'd like to spend a little bit of time thinking about treatment as well of high blood pressure in patients treated with dialysis. We alluded to before that volume overload is a critical contributor of hypertension in this population. And so I think volume management is really, I would say, my first approach in terms of treating blood pressure in patients on dialysis. Attainment and maintenance of euvolemia is the cornerstone of hypertension treatment. And as you can expect, there are large fluctuations in this population in volume status due to the fact that they don't have normally functioning kidneys. And so there's lots of different approaches you can partake in to manage volume in this population. You can pursue ultrafiltration during dialysis, and this is a number that's set in the dialysis orders to achieve a specific dry weight target at each dialysis session. We can work with patients to limit intradialytic weight gain, mainly through reduction of dietary sodium. Diuretics can be used especially in those with residual kidney function who still make urine. And there is some evidence that lower dialysis sodium concentrations may also help with volume management. And volume management is tricky in these patients. As you can imagine, coming to dialysis and getting several kilos of fluid removed at one time is far from physiologic, and so this has to be balanced carefully with risk of intradialytic hypotension, is when your blood pressure drops too low during dialysis, often a result of too aggressive ultrafiltration. And intradialytic hypotension is not benign. We find that numerous studies have really demonstrated that even these short episodes of low blood pressure during dialysis can contribute to the loss of residual kidney function, are associated with myocardial stunning, cerebral ischemia, as well as mesenteric ischemia. And this is a schematic that I really like, in which it really highlights this balance between too little and too much fluid removal on dialysis. Too little, we get hypertension, LVH, congestive heart failure, and symptoms and other adverse consequences. But again, this needs to be balanced with too much ultrafiltration. So really using an individualized approach to figure out how best to get to a patient's target dry weight or euvolemic status. And so what about the data beyond ultrafiltration? So, there is some data on dietary sodium reduction. There was a meta-analysis of several RCTs that looked at 91 hemodialysis or peritoneal dialysis patients collectively, and they found that dietary sodium restriction was associated with an 8.4 millimeter reduction in systolic blood pressure. Additionally, really focused attention on dry weight can be a really nice approach to hypertension treatment as well. One of the trials that really investigated this well was the DRIP trial, in which 150 patients were randomized to a very intensive dry weight reduction strategy. And they found that over 8 weeks of using this intensive dry weight reduction strategy, in which there's greater volume removal during dialysis, this led to a significant reduction of 6 millimeters mercury in systolic blood pressure compared with placebo. And I do want to just acknowledge that, volume assessment is tough. It's one of the toughest things that we do clinically. And so I think there's an increasing employment and interest in using technology to help assist in volume assessment. And there's a lot of different tools you can think about, BIA, there's different ultrasounds, there's different apps that are being developed. Some of the best data that we have in dialysis patients is the use of lung ultrasound, which may detect subclinical pulmonary edema. And I think there's a few RCTs that are fairly small in this area, but show a possible effect in terms of helping guide dry weight reduction. And this is one that was published in 2019, in which they randomized 71 patients, and they used a lung ultrasound guided dry weight reduction strategy versus placebo, and did find that there was a reduction in systolic blood pressure. And for all of these interventions, I'd just like to note, the sample sizes are modest. Dialysis patients, studies of dialysis patients are challenging to recruit, but I think that this is a growing area that future research should really focus on. And so what do we know about medications? So antihypertensive medications, I would say we use nearly all the classes of antihypertensive medications in dialysis patients. We have limited data on testing specific classes for treatment of hypertension. And so I use a very pragmatic approach in terms of how to prioritize which classes to use, thinking about other possible benefits that the agents may offer. So for example, in a patient with residual kidney function, we commonly employ loop diuretics, which can help with volume control, hypertension, and work with their residual kidney function, which is a plus. For cardiovascular benefits, there's been data on carvedilol, especially in patients with heart failure with reduced ejection fraction. Mineralocorticoid receptor antagonists, balancing the risk of possible hyperkalemia. And then ACEs and ARBs do remain a mainstay of hypertension treatment in this population, particularly since many patients are on this during the CKD phase of disease. However, I think there's still some inconsistent findings from small studies about the benefit of these medications in patients on dialysis. The other unique characteristic to consider when thinking about which medication to use is dialysability and the choice of medications. And so why is this important? If drugs are dialyzed off, they simply won't be effective. It affects the pharmacokinetics of the medication and affects the timing of blood pressure medications as well. Whether or not you dose the medication prior to or after dialysis, for example. And so how is this determined? How much a medication is dialyzed off depends on the magnitude of protein binding of the medication, the volume of the distribution, the molecular weight, as well as interactions with the dialyzer or hemofilter membrane. And so this is a table that was included in our scientific statement, in which we summarized the different classes of antihypertensive medications by how well dialyzed or not dialyzed they are. And so you can see here we highlight the ones with low dialyzability, and if possible, those are the preferred agents. And timing of blood pressure medications are also quite important in this population. I think whenever I start a medication in a dialysis patient, I always think about pill burden. So to remind you, on average, a dialysis patient takes 19 pills a day. So thinking about how best to use medications that reduce patient burden is really important. Nocturnal dosing, and so this has been a popular approach in some patients. just remember in patients that are treated with dialysis, they often have disrupted sleep patterns from the physiologic effects of uremia itself, as well as simple things like dialysis scheduling. Some of them have 5 a.m. dialysis runs, which affects their entire sleep patterns. And then finally, we already talked a little about timing around dialysis, considering, whether the types of medications and whether they're dialyzable or not, and the effects on ultrafiltration rates. So unfortunately, this is also an area that we need more data, but there are studies ongoing in this space. So to summarize, nearly all patients treated with dialysis have hypertension. Hypertension is a key modifiable contributor to the dismal rates of cardiovascular disease and death in these patients. I would say that it's important to remember blood pressure management in the general population does not equal blood pressure management in dialysis patients. And there are many key areas that need future investigation that have been highlighted, in fact, in our scientific statement. So I encourage you to take a look at these areas as you plan your own studies. And I want to really give a huge thank you to our writing committee. This was truly a collaborative effort. A special thank you to Dr. Glenn Chertow, who is the vice chair of this scientific statement, as well as the remainder of the writing group, many of whom are with us today on this webinar, so thank you. And this was a collaborative effort with several councils with the American Heart Association. So thank you.
Thank you so much. Should we just move right into the case presentations with Dr. Cohen?
Yeah, with pleasure. So Nisha, thank you, or Dr. Bansal, I've learned a lot from you about management of hypertension on dialysis, particularly from the research you've done in this space. And as somebody who had my own dialysis shift until this past year and have struggled with also being the one called as the nephrologist to help manage several difficult cases of patients' hypertension on dialysis, I chose 2 select cases today that I thought were particularly representative of some of the challenges that Dr. Bansal alluded to in her talk. So the first case is a 72-year-old gentleman with a past medical history of end-stage kidney disease due to IgA nephropathy and long-standing resistant hypertension for over 20-30 years. He's been on hemodialysis for the past 4 years. He notes that he feels very, very fatigued on non-dialysis days to the point where it's very negatively impacting his quality of life and preventing him from watching his grandkid, which is pretty much the main purpose of his livelihood at this point. He has been struggling with high blood pressures, though, on hemodialysis, with a lot of recent up-titration of his antihypertensive medications as a result of that. Most recently, after these up-titrations, his pre-dialysis blood pressure remains elevated in the 150s to 170s, over 70s to 110s. Of note, all of these blood pressures, except the intradialysis ones, include the range for both sitting and standing. He's not orthostatic. His intradialysis blood pressures have ranged in the 180s to 220s, so going up during dialysis, over 90s to 120s. And his post-dialysis blood pressures remain elevated in the 170s to 220s, over 90s to 110s. He has no residual kidney function, so he does not urinate at all any longer, and he notes that his intradialytic weight gains have long been a struggle since starting dialysis, but in the last 2 years, he's really been working hard at reducing his sodium intake and reducing his intradialytic fluid intake in concert with his nephrologist, who lowered his dialysis sodium levels a bit so that he wasn't craving as much fluid between dialysis treatments. And he ended up, and that's not evidence-based, more anecdotal, but he ended up with only 3 kilogram fluid intake now between sessions, which he's typically able to remove. He starts cramping and becomes hypotensive upon attempts to try to challenge that weight further and remove more than 4 kilograms with dialysis. All of his antihypertensive medications he's been instructed to hold on dialysis days. This is based off of his dialysis unit's admission orders. I'll include a note to tell all patients to hold all of your antihypertensive medications before dialysis. His medications include amlodipine 10 milligrams daily, lisinopril 40 milligrams daily, metoprolol succinate 100 milligrams daily, Hydralazine, 100 milligrams twice daily. So he takes the second dose, he skips the first dose, but takes a dose in the evening after dialysis. And clonidine, 0.3 milligrams twice daily. Similarly, he skips the morning dose, but takes the dose in the evening before dialysis or after dialysis is over. And then on non-dialysis days, takes it twice daily. So in summary, the 72-year-old gentleman with end-stage kidney disease who's been on dialysis for 4 years and has a very long-standing history of hypertension notes that he is very fatigued on non-dialysis days. That's really disrupting his quality of life. He has peridialysis hypertension, particularly a rise in blood pressure throughout his dialysis session and after dialysis. And he's currently taking amlodipine at maximum dose, lisinopril at maximum dose, metoprolol succinate 100 milligrams daily, hydralazine 100 milligrams twice daily, and clonidine 0.3 milligrams twice daily, all of which he's been instructed to hold before dialysis. So first, I'd like to ask our panelists if you have any questions about this case or any next steps that you'd recommend in evaluating or managing this patient before I go on and talk about some of my ideas.
I can go first, I guess. Well, thank you. So far, it's been excellent talk from Dr. Bansal and Dr. Cohen. I learned a lot. So at least I'm the only person who's not a nephrologist in the crowd. So I think that from this I can see already. I'm not sure why it's whole on dialysis day. So it seems like the first thing first is seems like simple things. Unless I don't know something else that I'm not aware of, I wouldn't hold it and consider. According to the document, that something like lisinopril and metoprolol probably not the best thing on that easily get dialyzed. And also there's some data that carvedilol may be particularly good in people with at least effective in people with intradialytic hypertension. We were part of a small study a long time ago with Dr. Enric that showed that it's particularly effective and may improve nodular function more in people with dialysis, with intradialytic hypertension. So I always consider that.
Yeah, and I would just add that it's very critical to know which of these drugs are dialyzable. And basically, this patient's blood pressure remained high throughout the treatment. And so it doesn't appear to be entirely volume mediated, because the patient was cramping. He was taking a good bit of fluid off, almost 4 kilos. One other important point is that the time frame of the dialysis, I'm not sure how long this patient runs. So that's one question, because you don't want to pull more than 1 to 1.5 liters per hour. And if he was approaching 4 kilograms, if he was running less than 4 hours, that would definitely cause cramping. But I think in this particular case, it's more of the medications that some are being removed with dialysis, such as lisinopril, metoprolol, and that you would want to change that regimen to something that's not dialyzable.
Yeah, these are all incredibly important points. Thank you both. The question about how long he is being dialyzed for. So this patient, but not the next patient, this patient was on my dialysis shift, which was a nocturnal dialysis shift, where I had the luxury of having my patients dialyzed for 8 hours a night, 3 nights a week. To be allowed on the shift, they had to sign a waiver saying that they would agree to stay for the full 8 hours. And not go any less than that. And it was a very self-selected, very adherent and amazing group of patients, that many of whom worked the next day or did things like care for their grandkids the next day. So the fact that he was having so much intradialytic fatigue was worrying to me, because this is very uncommon on that shift, but I left that out just for to leave out a detail and for conversation. So it's a great point. Most of us don't have access to that, but when we don't have access to that, we should at least have access to what you're alluding to be able to give people at least an hour longer treatment or an additional treatment to allow to attempt additional UF to make sure that we've truly pulled enough fluid on these patients, particularly the ones who have no residual kidney function and we can't give a diuretic to help them remove additional fluid between dialysis sessions. So these are all really important points. The thing that I really want to know about this patient too is with this intradialytic fatigue is what are his blood pressures when he's not on dialysis? He comes in with very high blood pressures, but this is after he's holding his morning clonidine and hydralazine, which are such short-acting medications, that it's not surprising to me that he has that high of a reading, but might have very different blood pressures on alternative non-dialysis days when he's taking his medications. And so in him, I think just even starting with home blood pressure monitoring would be phenomenal. In a perfect world, our gold standard is 44-hour ambulatory blood pressure monitoring. But we had done, based on Dr. Bansal's pilot study that she'd done with Chishu, we looked at just patients' responses to how they handled 44-hour ambulatory blood pressure monitoring. And it's a big burden on patients. A lot of them, some even called it intolerable and really would refuse to do it again even if you offered the money to do it. And whereas home blood pressure monitoring, these patients often love. They find it empowering. They find it an opportunity to be engaged in their care. It's not a perfect answer. Not everybody can do it appropriately or can follow the instructions to do it, or may have barriers to being able to do it, such as not having a home to be able to check their blood pressures in. But I think in the majority of cases, we're able to do it quite effectively. And I think that it can really help guide management quite a bit. And so per your other point, the other really important things to consider is the dialyzability. And that's what both Dr. Vongpatanasin and Dr. Lay brought up. And so really great options of medications that have low dialyzability, particularly for a patient with intradialytic hypertension, are something that we should really be thinking about. These recommendations to hold antihypertensive medications prior to dialysis are often very, very common because people are treated with medications with high dialyzability, and then there's this concern that like they're going to get dialyzed off, but they're not even taking it in the morning. And these medications with low dialyzability really only create a problem in patients with intradialytic hypotension. And then if that's happening, we'll talk about in the next case, there are other things to also be considering, and there may be adjustments that can be made that are patient-specific that can help. And so for this particular patient, since he has intradialytic hypertension, reintroducing antihypertensive medications prior to dialysis may help with some of the rebound hypertension, particularly from holding clonidine and from holding hydralazine, and also changing to dialyzable medications, or changing dialyzable medications to non-dialyzable medications can really be helpful. And so with him, what I ended up doing was I recommended the home blood pressure monitoring, and his home blood pressures on non-dialysis days went down from these like 220s over 110s readings to the 90s over 40s on many readings. His average was about 90, if I recall, it was about 98 over 52, compared to truly having diastolic blood pressures that were 50 points higher on before dialysis. So poor guy was just having extreme swings between sessions. And just by slowly introducing his antihypertensive medications on dialysis days, we saw big improvements. And then what we slowly did was try to simplify his regimen and get him on better medications for him per that wonderful chart from the AHA scientific statement. So we tapered off his clonidine. We changed the lisinopril, which has high dialyzability, to telmisartan, which has lower dialyzability. And we changed the metoprolol to carvedilol, as Dr. Vongpatanasin mentioned, since it's been shown to have benefit in many of these patients, and at least in the small studies that we have. And so 6 months later, he was doing much better. His pre-dialysis blood pressures were in the 150s to 170s over 70s to 90s. So not perfect, but a very vast improvement compared to what they had been. His intradialysis blood pressures were 110s to 140s over 50s to 70s. So no more of the severe intradialytic hypertension in particular. And his home blood pressures, which is what I put the most weight in, were running in the 120s to 140s over 70s to 80s. And we looked at his clinic blood pressures as well, and we established that we think he also had some white coat hypertension. So I think that this combination of medications really proved themselves to be a much better fit for him, and really, really love referring back to this table as often as I can for reference when thinking about how better to manage these patients. Any questions or comments on this case? Somebody asked, would you consider a clonidine patch instead of a pill in addition to the changes made? And I think, yes, if he still needed it, like if his blood pressures were still elevated, I most definitely would use a clonidine patch or guanfacine in a patient like this. I find the clonidine patches can be fabulous in these patients because you're reducing pill burden in a group of patients that are on often, as Dr. Bansal had mentioned, a dozen medications a day, if not more. And so I think it can really have a big impact on quality of life to offer a patch, and the long-acting nature of it can be quite helpful to prevent wide swings. A lot of these patients are very sympathetically active as well, and it can help with that. Prolonged or frequent dialysis sessions to remove excess fluid. Well, this patient has prolonged dialysis sessions, so yes, thank you. But yes, in many patients, that also is an answer if they don't already have it.
Before you go to the next case, Dr. Cohen, I just want to make sure everybody knows, I want to reiterate that there is a little button at the bottom of your screen if you're listening here that says Q&A, and that's where you can put your questions in for the panelists to field as those arise. Thank you.
And then Dr. Jan Bansal asked a great question. Should hypertension in hemodialysis patients be controlled by the nephrologist dialyzing the patient? And so that's a very, very good question. It depends, I think, a lot on the model of the particular health system. I was seeing my patients weekly, and I definitely was managing my patient's blood pressure. And I think, yes, that should be the case, because the nephrologist is the person who's capturing the most data on the patient's blood pressures. Often the providers outside the dialysis unit don't even have access to those blood pressures. But I think that if they're doing that, they need to be looking at their non-dialysis blood pressures, as Dr. Bansal presented in terms of the data, that so much of the non-dialysis blood pressures matter, perhaps more than their dialysis blood pressures. Yes, that's all. It's often the nephrologist managing it. It's often, though, interdisciplinary. I don't think anyone should be an island. Often, most of these patients have heart failure and are seen by cardiologists as well. Most of these patients have very involved primary care providers who have a lot to add and understand a lot of the context of what the patients are dealing with just as well, if not better, than we do as the nephrologist. And so I think it should never just be a single nephrologist managing it. Dr. Bansal added, primary care clinicians don't know about this data and how best to do this. That's what we hope the scientific statement will bring forward, so that more people have access to this information, but it is a great point. Dr. Bansal, anything you want to add to that?
No, I agree. I think, communication is key. What we want, sometimes non-nephrologists discount the importance of the blood pressures they're seeing in their clinics. And so, I think going forward with a good interdisciplinary plan and looking holistically at all the blood pressures, all the medications, indications, and quality of life, et cetera, is important.
Gosh, I think if you're willing, the cases are just so illustrative. If you'd be willing to proceed with the second one, even if you have to shorten it at all, I just think we just learned so much from those, unless anyone on the line objects.
I think it'll actually help with the next question, because somebody's asking about midodrine. So let's go on to the case number 2. So case number 2 is a 65-year-old woman with a past medical history of end-stage kidney disease attributed to longstanding type 2 diabetes, as well as hypertension, coronary artery disease. She's had a 3-vessel CABG about 10 years ago, stable angina, and she's been on dialysis now for about 12 years. She's been struggling with symptomatic labile blood pressures over the past 6 months that have included multiple falls attributed to hypotensive episodes. Her pre-dialysis blood pressure is in the 190s to 120s, over 80s to 110s. She has asymptomatic highs, so not complaining of any headaches, any chest pain. These are chronically her numbers that she's had repeatedly. Her intra-dialysis blood pressures typically drop quite a lot and range between the 50s and 90s, most often on the lower side of that range, over 20s to 40s. She says that she very frequently on dialysis sees stars, is dizzy, and often goes to sleep because she is feeling so lightheaded and dizzy, which makes the staff concerned, because then her blood pressure drops further as she falls asleep on dialysis. Her post-dialysis blood pressures range from the 90s to 190s, over 50s to 90s. She's intermittently orthostatic, but not consistently orthostatic. And she notes that she's wiped out the rest of the day. Also of note, she checks home blood pressures because she's really engaged in her own care and worried about these readings, and has noted very, very broad home blood pressures, between 70s to 200s seated blood pressures. And that she says, though, she sometimes forgets to take her medications or to hold them before dialysis. Sometimes she thinks she might take them twice on some days because she doesn't remember if she took them. Sometimes she gets very dizzy after taking her medications. That's how she knows she definitely took them. Her interdialytic weight gains typically are 3 to 4 kilograms, but she only tolerates 2 to 3 kilograms of fluid removal at best with each session because of the low blood pressures that she's been having intradialytically that are symptomatic as noted. So her ultrafiltration is often held. That's including when we tried shifting her to 8-hour shifts. Her medication lists, all of her medications are held pre-dialysis. They include amlodipine 10 milligrams daily, olmesartan 40 milligrams daily, carvedilol 37.5 milligrams twice daily, hydralazine 100 milligrams twice daily, clonidine 0.3 milligrams twice daily, doxazosin 8 milligrams twice daily, as well as the dialysis clinic order set that includes clonidine 0.1 milligrams PRN for blood pressures of greater than 180 over 110, which is something she frequently reaches in her pre-dialysis blood pressure. This is a very common standing order at dialysis units. So in summary, the 65-year-old woman with a past medical history of end-stage kidney disease due to longstanding type 2 diabetes, who's a known vascular path with coronary artery disease, stable angina, and longstanding hypertension, who's been on dialysis now for 12 years, is struggling with pre-dialysis asymptomatic hypertension, intradialysis symptomatic hypotension, interdialysis symptomatic blood pressure lability, taking a very complex regimen of 6 antihypertensive medications, which she's told to hold before dialysis, but she struggles with her adherence as to whether she's always taking or not taking with all the best intentions. What would be your next steps in evaluating and managing this patient? Do our panelists want to chime in with any ideas?
Yes. First of all, excellent case. This woman with diabetes, you also wonder about if she has any autonomic dysfunction and orthostatic hypotension, and even part of the standard dialysis monitoring there to do pre and post-standing blood pressures. So when she's feeling dizzy at home, etc., I'm wondering, is some of that, first of all, due to excessive fluid removal, but also due to autonomic dysfunction? So I'd like to know if there's what her patterns are, because I don't think you mentioned what the standing blood pressures are. And then the second point is the doxazosin also can precipitate, orthostasis. And then she's on a pretty high dose, 8 milligrams twice a day. So those are my two sort of comments about this case.
Very important points. Thank you. So she is intermittently orthostatic. Sorry, I think I said it very, very quickly. So intermittently she gets orthostatic hypotensive, but not consistently with those lows. Some of those lows are seated lows. We've checked a 44-hour ambulatory blood pressure because similarly we're concerned about autonomic dysfunction, which is a very real concern in people with longstanding diabetes that's caused their kidney disease. She did not have any supine hypertension. Her 24 to 44-hour ABPM really didn't give clues of autonomic dysfunction. It more just looked like her blood pressures dropped after she took her antihypertensive medications. But it's a very, very, very important point.
So for me, I probably would want to know what her, whether she had left ventricular dysfunction, at least to get me an idea whether how much GDMT I should keep on the list. So obviously, it sounds like the medication should be cut at the minimum, because that's the easiest step is to avoid hypotension. But I would like to know which one should I try to keep. I definitely would think about, even if to keep them, we can even simplify to turn to something more dialysable, do the reverse thing that was done in the first case. And it seems like she's on too many drugs, and for her blood pressure, I think we can cut down quite a bit too.
I completely agree with you. And so somebody had asked the question of whether midodrine is good for these patients. I can't tell you the number of people I have had referred to me who look like this, where they're on these very hefty antihypertensive regimens, plus midodrine 30 minutes before dialysis. And that is never the answer. The answer is always get a better regimen of antihypertensive medications. Really, midodrine should only be used in people who perhaps have cirrhosis and really preload dependent patients or autonomic dysfunction, where you really have a true reason that you would think they would need a pressor. But not in this patient for sure, and is very rarely the right answer. Not very rarely, but only in those specific circumstances. One thing I wanted to go back to is Dr. Bansal's point about these peridialysis blood pressures. This is somebody with severe intradialytic hypotension. We know that that blood pressures that are both low and high around dialysis are dangerous. That it's not clear exactly what the sweet spot is, but they at least are associated with adverse outcomes. These are all in epidemiologic studies, so there could be other factors involved. Many confounders could be relating to this, including measurement issues. But we see that particularly intradialytic hypotension has been associated, as Dr. Bansal mentioned, with mesenteric ischemia, with myocardial stenting, and there's even some epidemiologic data associating it with adverse outcomes like myocardial infarctions, cardiovascular mortality, all-cause mortality. And so really that's what worries me most, because a lot of the intradialytic hypotension, not all of it, but a lot of it can be avoided by better regimens. So if we're thoughtful about it and really consider this table carefully, try some changes to see if we can try to reduce some of that intradialytic hypotension, we can sometimes have substantial impact on this patient's outcomes when it's already somebody at very, very high risk of adverse outcomes by their existing medical factors. And so for this patient with intradialytic hypotension, as Dr. Vongpatanasin mentioned, we should be focusing on more dialyzable medications. This is somebody who's on several medications with low dialyzability that she's not really remembering if she's holding or not holding before dialysis because it's such a complicated regimen. Some of them are probably not helping her. As Dr. Lee mentioned, the doxazosin may be worsening things rather than helping things in her situation. And so I think simplifying her regimen, but also trying to get her on medications that'll be more appropriate for her. And most importantly, avoiding short-acting as needed medications. She has this very high pre-dialysis blood pressure that becomes low because she has this range that is in a scary number that someone's treating with the clonidine pill, and that's really exacerbating her intradialytic hypotension. And that's, of course, the most obvious initial step. But if you go around the country and look to see what's done, a lot of these units have, again, these standing orders. A lot of nurses, understandably, are very scared by these high numbers and feel that they're doing the patient benefit by treating this high blood pressure number and aren't understanding or not appreciating that they're causing more harm than good by doing that. And I will say that I had so many late night calls even on my nocturnal shift. This patient's blood pressure is high, what do I do? And typically the right response is remove more fluid, or if they can't tolerate it, watch it. But the right response is, and we'll change their medications appropriately based on the trend. But instead, most places, the response is, don't call me, let's put in a standing order, and we're going to just treat it with an as needed. So I think if there's anything that people take away from this is look at those PRN orders that are standing in your dialysis units, and please reconsider them. Diuretics are also underutilized, as Dr. Bansal mentioned, and so this plus increasing the duration of ultrafiltration can often be helpful for intradialytic weight gain and volume expansion, which contributes to hypertension in these patients. And so with this particular patient, what I ended up doing was discontinuing that as needed clonidine order, so nobody could ever give it without asking me, which meant an extra step for the nurse to have to call me, which was more work. So it didn't happen anymore. And change the clonidine patch, the clonidine to a clonidine patch, as was mentioned, and somebody had brought that up in the chat in the last case. So that simplification just took away like a lot of her fear of, I don't know if I'm remembering my medication, not remembering it, taking it too many times. We did the patch change on dialysis days, so our wonderful nurse could help her with changing her patch, so that it wasn't even a factor for having to remember it. We had it on her like order set, so it was remembered for this to be done on a particular day of the week. We also added an up-titrated torsemide to quite a high dose for non-dialysis patients. That was really helpful for her to reduce her intradialytic weight gain. So she was able to urinate out more fluid between dialysis sessions, and every small amount makes a big difference in these patients. So it really, really added up. And we also changed her amlodipine and olmesartan to a combination amlodipine benazepril and fixed dose combination, since benazepril is very dialyzable, and in her case, this was beneficial. And we changed her carvedilol to post-dialysis atenolol. This is the only time I would ever recommend using atenolol. Rajiv Agarwal did a really interesting trial where he randomized patients to post-dialysis atenolol, and found that this can be very effective because they only have to take it after dialysis. They don't have to remember to take it between dialysis, and it stays in their system between treatments. So in someone really struggling with adherence, or patients who struggle with homelessness, with other poor access to resources, this can be a very, very helpful intervention that can really help stabilize their blood pressures. And we stopped the hydralazine and doxazosin, as per Dr. Lee's very important point, that the doxazosin was probably creating some of those orthostatic hypotensive episodes. And if not, then it at least was a very, very high dose that it wasn't clear if it was really helping with her hypertension. So she went from having to remember 10 pills daily to 2 pills daily, and that was a game changer for her, and her blood pressure reliability has really narrowed. And so in summary, from my end, paradialysis blood pressure is really the classic target for volume management and antihypertensive therapy, but it's really suboptimal based on epidemiologic data, as Dr. Bansal presented. And these out of dialysis blood pressures can really be helpful and maybe better to target, but we of course need more data to know for sure. But anecdotally and with our patients, I think it's underutilized. And if you start using it, you can start to see perhaps the power of doing that. Volume is a major mediator of hypertension in these patients too, and really a lot of people don't think about giving them loop diuretics because they don't urinate a lot, but at high doses you can get enough that it can really be a game changer to help improve patients' quality of life, and these poor patients like measuring every sip of water they take. And carefully consider medication dialyzability in individual regimens. Just trying to simplify things can go a long way in helping with adherence as well, especially with people who have the best intentions, but when they're on 12 medications, really can struggle to know what's right. Especially when they have to hold some on dialysis days and take others on dialysis days, it really gets very complicated. So I think, any questions?
So Dr. Bansal asks if what do you think about peritoneal dialysis? It's a very interesting question because now we don't have to worry about the thrombosis of the AV fistula. So what's the blood pressure target in PD?
Yeah.
Dr. Bansal, do you want to take that?
Unfortunately in PD, our data is even more limited than we see in HD patients. And so I think it's a really important population, but you're right, there's very little data on these patients in terms of what our blood pressure targets should be and what our treatment approaches should be. PD has benefits in that, the volume control is done daily, which is really nice. And so I don't think that we can apply our same strategies that we use in HD to PD.
Excellent. There's another question on also the role of MRA, potassium plus minus potassium binder.
So I don't recall if MRAs are dialyzable. I know that's part of the question, but we usually would give a diuretic on non-dialysis days, and anyone who still urinates at least, to avoid preventing adequate UF on dialysis days. Dr. Bansal, do you remember if it's dialyzable?
I can't recall. I'd have to look it up. It's a really good question. In terms of potassium binders, MRA dosing in hyperkalemia, even in dialysis patients, is dose dependent. And so I would start with low dose, and often they can tolerate that without hyperkalemia. And the risk of hyperkalemia depends on the residual kidney function, obviously, but there is some bowel absorption as well of potassium, which can contribute. And then in terms of potassium binders, I try not to give more binders if we can avoid it. You can adjust their potassium bath. You can give diuretics, as Dr. Cohen mentioned. So, try to think about alternative strategies as best as possible.
Yeah, and I would just add that MRAs, I think, in general for dialysis patients is more suggested for cardiac benefit, not necessarily for blood pressure control. So whether or not it's removed with dialysis, I don't think is really that important. I mean, I think it may, helps to reduce cardiovascular fibrosis, etc. And so if there is a concern about doing that, I would always dose it after dialysis, but for blood pressure control, I don't think that's going to give you a great response.
Thank you. I think that's also to cardiovascular outcome trial too, right? I think that's coming out for the, we don't even know if MRA benefits you with hemodialysis. So even though I would love to think so, but it would be interesting to see.
And then there's a great question in the Q&A. Is there a recommendation for cardiac testing in intradialytic hypotension to evaluate for vascular disease or valvular heart disease? So I think whenever we see intradialytic hypotension, it should definitely cross your mind, is this patient preload dependent? And so I didn't mention, and that's a really great point, this patient had an echo that showed that they had HFpEF but no valvular disease. And I think an MRA would be a good thing to consider in that patient potentially. But I think in general, you should be thinking about severe aortic stenosis. You should be thinking about cirrhosis. A lot of our patients have cardiac cirrhosis too. And NASH, or it has a new name now, NAFLD, there's another name for it now, but basically fatty liver disease. So I think all of those should be part of your evaluation for intradialytic hypotension, but I would first rule out iatrogenic and make sure that it's not just giving them the clonidine pre-dialysis. Maybe do both in concert with each other, of course, because not everybody gets intradialytic hypotension who gets all of our interventions. But that all of this should be part of your consideration.
Wow,
Yes.
we're at the. I'm sorry.
I don't know. We have time. I'd like to ask one more question. And
Please do. You get the final question.
okay. Yes. So oftentimes I have a few patients who will prescribe like sodium bicarb, and if you have like hypertension and control, like what else can we do to correct metabolic acidosis while giving sodium bicarb?
We can adjust the bath on dialysis for that in particular. So that is definitely something that can be done on the dialysis.
I see. And without the pills, I have a patient who's like uncontrolled blood pressure, and they give me 5 sodium bicarb pills a day. It's like, what do I do with this? It's very difficult to tell people to restrict salt and give them sodium bicarb.
I would say that patient is not getting adequate dialysis if they have to take that much bicarb to control acidosis, or they're eating way too much protein. So I think some dietary adjustments and more aggressive dialysis should correct that.
Excellent. Thank you.
Wow. Well, this has been such a marvelous discussion, and I think fortuitously we reached the end of the Q&A questions just in time. So just want to thank all the presenters and panelists and the organizers and most importantly the attendees for tuning in today. Thank you very much. I apologize for any questions that may have flown under the radar, but I think we answered all the ones that were visible, but wanted to let you know that this session will now be posted on the AHA Lifelong Learning page. For any of your friends or family who may have missed it, they can tune in there. And again, we just really appreciate all of you being present today and wish everyone a great week. Thank you so much.
Thanks.
Thank you. Thanks for everyone for joining.
Thank you.
Cheers.